that's okay. Good afternoon, everyone, and welcome to Wellstar's presentation on Parkinson's disease with Wellstar's very own movement disorder specialist, Dr. Young. Just a little bit about Wellstar. Wellstar is one of the largest health systems in Georgia with 11 hospitals, over 300 medical offices, 17 urgent care locations, 55 rehabilitation centers, and so much more. We strive to improve your health and wellness so you can live your very best life. At Wellstar, we are more than healthcare, we are people care. So if you need to find a physician, please visit our website at wellstar.org or call 770-956-STAR, and that's 770-956-7827. We are so glad you have chosen today to attend to learn about Parkinson's disease and the falls risks in Parkinson's patients. I would like to briefly introduce Amy Waddell with Cobb Senior Services for her to give some information about a wonderful program called Share the Care. I'll turn it over to you, Amy.
Thank you so much, Elise. Can you hear me?
Yes.
Okay, just briefly, I wanted to thank again Wellstar for this presentation and share some information about Share the Care. It is a program to assist folks with dental, vision, hearing, and some prescriptions. It's a new program for us. I have put the link and the phone number for more information in the chat box. And it is for individuals 60 and older living in Cobb County with neurological conditions such as Parkinson's. So if you have any questions, please reach out to us.
Thank you, Amy. Just a reminder, we will do a Q&A at the end. So if you have any questions throughout the presentation, please feel free to put those in the chat box and I'll make sure that they get answered. Without further ado, I'd like to introduce Dr. Young. Dr. Young is a board-certified neurologist specializing in movement disorders. She is a member of the International Parkinson and Movement Disorder Society and the American Academy of Neurology. She previously served as the Movement Disorder Service Line Director for Centra Medical Group Neurology in Lynchburg, Virginia. Dr. Young also serves her community and is an active member of Delta Sigma Theta sorority, the Lynx, and Jack and Jill of America. She currently serves on the board for the YWCA of Central Virginia in Lynchburg. I'm going to go ahead and turn it over to you, Dr. Young, and I'll take care of your slide advancement.
Okay, thank you, and good afternoon. Can everyone hear me okay?
I can hear you.
Okay. So thank you for having me come and speak with y'all today. So today I'm just going to be focusing on one topic in Parkinson's disease, and that is particularly falls. So I was I was told that you guys were really interested in talking about falls and all of the things that we as neurologists are thinking about when we start discussing your falls and how to help reduce them. So we can go to the next slide. So I'm going to give a little bit of background about Parkinson's disease and just the pathology, the typical clinical features, both in the motor and the non-motor side. And then we'll talk about some Parkinson's disease related falls. And then I'll kind of highlight some non-Parkinson's disease related falls to also be aware of. So next slide. So Parkinson's disease is a disease known as a neurodentive disorder. So what that means is that neurons in the brain are dying. In particular, as it pertains to Parkinson's, those neurons are neurons that make dopamine. And dopamine in a part of the brain called the basal ganglia is very important for making sure your movements are smooth and coordinated and fast. So even if you're not weak, like even if you have full strength, if you didn't have dopamine, you would not be able to execute your movements in a smooth and fast fashion. So with Parkinson's, you will notice that the patient will get stiffer and slower. And that is mainly because they don't have enough dopamine that they're making anymore. They don't have enough neurons that make that dopamine. So here on the slides, the one on the right are just two cuts of a part of the brain called the substantia nigra. On the far right, that cut is showing a really kind of dark brown, almost black line. And that is what the substantia nigra should normally look like. And the pathology slide right next to it is what it looks like in Parkinson's disease. So as you can see, it's not as dark, and that's actually showing that there's less neurons in that area that make dopamine. We can go to the next slide. So the typical features that most of us are aware of for Parkinson's disease are the motor symptoms. And when a patient starts developing Parkinson's, or they start presenting with Parkinson's symptoms, they'll end up having a low tone to their voice, so they have a really hard time projecting their voice. Occasionally, their voice may even be hoarse. They may develop a resting tremor in one of their hands, and typically, at least in the beginning stages of Parkinson's, that tremor will resolve when they go to move. So a typical scenario will be a patient coming in and saying, yeah, my family members tell me that when we're watching television or we're eating dinner, the hand that I'm not using may start shaking. But if I look at my hand or if I go to reach for the remote or a fork, it usually goes away. And so they're not always bothered by it in the beginning. Now that can change over the course of time with Parkinson's, but that's more so the more typical presentation in the beginning. Patients will also mention that their handwriting gets smaller. They just can't have a harder time making big fluid movements with their hand when they're writing their name, and it doesn't matter if it's in script or in print, but they'll have a lot smaller handwriting. The next one is that slowness of movement and that difficulty standing from a seated position. So most people, when we're sitting for a long time, we will feel sort of like a little bit achy or have a harder time getting up, but that's not it's not common that that's gonna be very severe. But in Parkinson's patients, they'll have a lot of balance difficulty changing from that position of sitting to standing. And they may even have to try a few times before they actually will fully be able to stand up in a straight position. Next one is freezing or difficulty initiating steps. So unfortunately, a lot of Parkinson's patients know this one very well. They will, they will be walking along and then all of a sudden their feet will sort of just freeze up on them. We're going to talk about that a little bit more later. And then there's a shuffling gait. So this is also going along with some of that freezing. They're making these really small steps. They're bent over a little bit at the waist. When they turn, they have to make multiple steps just to make a regular turn. And then the last one is that reduction in the movement of their arms, and they have a hand tremor. So that goes along with that stiffness again. Their arms just don't move as well, and then that hand tremor comes out. I forgot to ask, is it possible we could play the YouTube video that's on there? You may have to like copy and paste it into something, or if that's too difficult, I can show it at the end.
I'll pull it up to show at the end.
Okay, thank you. Okay, so we can go to the next slide. Okay, so then we have our non-motor symptoms of Parkinson's disease. And so sometimes when I ask patients the questions that I need to know to find out if they have these symptoms, they may be kind of taken aback because they're not really sure, why I'm asking them, what does that have to do with Parkinson's? Well, we do know that there are many other symptoms of Parkinson's that do not have anything to do with the motor signs. So it's more than just stiffness and slowness. It's more than just tremor. They may have some other things. And those things include a decrease in the sense of smell and constipation. Those things can actually happen 10, 15, 20 years before a patient ever has motor symptoms. Now you can imagine it's probably pretty hard to say, oh, well, if I'm constipated, I might have Parkinson's in a number of years. So that's not a symptom that we use to help diagnose, but it is a symptom that we associate with Parkinson's. Some patients may have some lightheadedness. This lightheadedness may even be more, severe to the point that they may even pass out when they stand up. And that's something called dysautonomia, or orthostatic hypotension is usually what the patient is diagnosed with. And their blood pressure basically drops when they stand up. So a lot of patients will know, oh, I might feel lightheaded, like I'm going to pass out. Some sleep disorders that patients may have. They may have some insomnia, so they just have difficulty falling asleep and then even staying asleep. They have something called Rem Behavior Disorder, which is a disorder where when you're sleeping and you actually go into your rapid eye movement sleep, which is where you dream, these patients will dream and they'll actually act out their dreams. So most people do not act out their dreams when they're asleep, but a patient with Rem Behavior Disorder will act out their dreams. And then restless legs is another one. So a patient goes to sit down in the evening or, go to sleep, and they just have this urge they have to move their legs. So it's very uncomfortable because they have to kind of get up and walk around just to make that discomfort go away. Now, with all of these, once again, you don't just having it doesn't mean you're going to have Parkinson's. There's a lot of people that have restless legs who do never go on to develop Parkinson's disease. So it's not one thing that we use to just diagnose it, but it is an associated symptom. And then the last two things are kind of mood and cognition changes. Patients will say, yeah, I've been just maybe more anxious for the past few years, or they've had some mild word finding or memory difficulty. Okay, next slide. So now we're going to get into kind of the main topic of the presentation, which is falling. So common, scenario I have is a patient coming in, they're like, doc, I'm falling, or, I'm losing my balance a lot. And so questions that I may ask are just for descriptions of these falls. Is the patient falling backwards? Are they falling forward? Are they falling because their feet are freezing up and they can't initiate that step? Is there any environmental stuff that's going on? Is there unsteady flooring? So sometimes I have patients who are falling in the house, but occasionally I have patients, they may say, well, I fall a lot, but then they're falling outside. Maybe they're a gardener, or they do a lot of outdoor activities. I've had some patients who, they're still hiking a little bit and their balance is just not as great anymore on those unsteady surfaces as it used to be, let's say 10, 15 years ago. And then there's also the question of the lightheadedness or that loss of consciousness associated with these falls. Another thing I may want to know is about the timing of these falls. Are the falls at random? Or are the falls occurring when medication is starting to wear off? Is the falling more in the morning? Is it after meals? Or is it just when they're performing multiple tasks? That's another really important one, because as our balance gets more, as we become more off balance, when you try to do multiple things at one time, it's actually going to be harder to maintain proper balance when you're doing that. So a common scenario I might get is someone saying like, oh, well, I was doing fine. And now whenever I'm like carrying the laundry up the stairs or down into the basement, I just find that I get off balance more. And that's because they're having to concentrate on not only walking, but carrying an item in their hands, and their balance is off. I also want to know if there's any other associated features. So I mentioned that lightheadedness and loss of consciousness already. I also want to know if they're having any numbness or tingling in their feet, any back pain. This is going to help me to determine the cause of the falls. Is that patient falling just because it's Parkinson's, or there's potentially something else? And I have a few reasons there, but we're going to get into those reasons next. So we can go to the next slide. Okay, so for the first part of this presentation, I'm going to talk about our Parkinson's related falls, and then I'm going to kind of end it up with some non-Parkinson's related falls. Next slide. Next slide. Okay, so the first one is shuffling gait. So the description of shuffling gait is really a patient who's making really short steps and they cannot lift their feet. So you're gonna, most people, and you'll see the video at the end, most people will have probably seen someone who's making these really tiny steps. They cannot really stretch their leg out too far, and they're really not lifting their feet. They're really kind of, for lack of a better word, they're just shuffling. They're shuffling their feet as they walk. And the questions I may ask them when they say, well, they're having more problems with shuffling, and that's possibly contributing to falling, is that shuffling responsive to their Parkinson's disease medication? So I want to know, is it worse in the morning, or is it worse near the time for their next dose? So this may indicate that the patient may have a dopamine responsive shuffling of gait. So that's kind of that stiffness and slowness. That is one of the things that actually normally would respond to medication. However, some patients can also have a shuffling of gait that is not responsive to Parkinson's disease medication. And it's really important that I differentiate between the two so that we're not just increasing meds and not never seeing an effect. Or that we're not increasing meds, assuming that this is a non-responsive shuffling of gait, and then, unfortunately, that patient not getting the benefit of hopefully being able to walk a little bit more fluidly. So we can go to the next slide. So here is where I'd like to just kind of talk a little bit about all the different medication options, because we have our dopamine responsive shuffling of gait in some patients. And so most patients with Parkinson's disease, or people that are familiar with patients with Parkinson's, are probably familiar with the name Carbidopa Levodopa. That is a dopamine replacement. Basically, the levodopa is converted to dopamine in the brain. And so it's basically like giving the body back something that it was missing. Remember, I talked about in the earlier slides, patients have lost neurons that used to make dopamine. And so they no longer make enough dopamine themselves. So now we give them dopamine in the form of levodopa. It's converted to dopamine, and then they can hopefully move better. There are two main formulations of this. There's Cinemet, which most people are familiar with, and then there's Rotari, which is like an extended release combo pill. There's another one that I left off of here, but it's Stalevo, and it's Carbidopa Levodopa, and then it also has another medication with it. Our next category are the dopamine agonists, and so that's pramipexole, ropinirole, and Vertigo. Those are medications that are not actually dopamine, but they activate dopamine receptors. And so, you know, when it comes to when we account for trying to make sure that our body does certain things, it's all about what molecule we have and then what receptor that molecule is activating. So in this particular case, our dopamine agonists are able to activate our dopamine receptors the same way that dopamine would. So they act very similarly. And so if we're talking about a dopamine responsive shuffling of gait, I would expect that a patient on one of these medications would notice a difference with their shuffling of gait. Their shuffling of gait would actually be better. And then maybe as it becomes time for their next dose, they may notice that shuffling of gait worsening again. There's also another group of medications that we may sometimes use in combination with the first dopamine replacement and dopamine agonist. And those are medications that help to increase either your dopamine that you're kind of making yourself or utilizing yourself, and reduce dopamine clearance. So one of those is Amantamine. It's been around for like over 100 years. It was actually kind of found by accident to actually help patients with Parkinson's, but now it's actually mainly used for Parkinson's disease. It has a few other indications, but it's mainly used for Parkinson's disease patients. The next group are your rasagiline and selegiline. These are medications that are going to help you to have a longer duration of dopamine around. And then entacapone, opicapone are also medications that help to reduce dopamine clearance, but they're doing that, you know, through a different mechanism from rasagiline and selegiline. And then I mentioned earlier with the Carbidopa Levodopa that when it's mixed with entacapone, it's a medication called Stalevo. So some patients will be on that, and so it's a kind of a one pill combination of 3 meds. Okay, we can go to the next slide. Okay. So our next topic, so we've talked about shuffling of gait, but the next topic that kind of falls along with the shuffling of gait is freezing of gait. So sometimes I have patients and they only have shuffling, right? They just cannot make those feet move very well, but they never really have freezing. So freezing of gait is a sudden, it can be brief, but it can be prolonged, inability to move the feet or initiate steps. And when a patient is having freezing of gait, I really do want to know, is it dopamine responsive or is it non-dopamine responsive? That's extremely important because unfortunately, a lot of patients with freezing of gait have a non-responsive freezing of gait. So I could increase their medication and it's probably not going to make a big difference. I also really need to know if it's occurring not only at a certain time with their medications, but also if it's occurring in a certain environment. So some common ones would be like narrow hallways or flooring changes, the threshold of a door, or crowds. And I bring this up because freezing of gait is actually worse for patients when they are changing position or if they're in an area where they don't have a lot of space. So the common times are, you know, in the office, we're sitting for a little while. I ask the patient to stand up and they start initiating that gait and they freeze, their legs sort of lock up. They can't really make that first step. So that's the first one. So when they first stand up to start walking. The next ones are that narrow hallway, or if they're in a home that has like hardwood in one room and then carpet in another room, they may notice that they're walking fine in the hardwood, and then the moment they go to walk into the room that has carpet, their feet sort of lock up a little bit and they cannot make those steps. The threshold of a door is another one, and that usually goes along with the flooring changes. And then I've also had patients just tell me that sometimes they're fine, and then let's say they go to the mall or they go some other place that has a lot of people, that crowd and that lack of space that they have will also cause their feet to lock up. So, you know, And freezing of gait is one of those things that really does contribute to falls, because usually the upper body is still sort of ready to go. And so, remember the patient usually has a little bit more of a stooped posture anyway, so they tend to have gravity sort of pulling them forward, but their feet, which are under them, are not really moving. And so it can be very easy for that patient to fall forward because they cannot get their feet to move. So there's a few tricks that we try to use with this. We don't have a great medication for freezing of gait, but a few things that can work. There have been some small studies that have been done with Amantidine, which we talked about before, and a medication called donepezil. So Amantidine is that medication that increases your endogenous dopamine. And in a small study, they found that patients who had freezing of gait noted that they did have an improvement in their freezing of gait for about 3 to 4 months. So, not a huge number of patients, only 11 patients, so not a big study, and not a long period of time, but 3 months is better than no months. So sometimes I will try this in the appropriate patient where it may work. And then donepezil is actually a cognitive medication. So we see it a lot with patients who maybe have Alzheimer's or Lewy body dementia, or even Parkinson's patients who may have progressed on to dementia. And there was also found to be some benefit with freezing of gait. And so there's actually another reason why donepezil may potentially be helpful. So whereas the shuffling of gait is really usually more related to that dopamine responsiveness, especially in the beginning stages of Parkinson's, freezing of gait tends to be more of a frontal lobe issue. And so that usually is a completely different neurotransmitter, and donepezil works on that neurotransmitter. So there is some thought that there may be some advantages to using donepezil because it works on this other neurotransmitter. Let me see, I think I had a couple other things I wanted to say about freezing here. Oh, so other tricks are, because it does seem to sort of be more frontal lobe or cognition related, sometimes I'll just tell patients, well, look, when you have a freezing episode, stop trying to move, right? So you just want to stop, take a deep breath, and then imagine yourself stepping over something. So if you're on a tile floor, and let's say the tile floor has lines or something, or you can see the lines on your hardwood floor, imagine stepping over that line. Instead of trying to make your legs move the way they normally have been for the last 50, 60, 70 years, just imagine yourself stepping over something. And patients with Parkinson's who have freezing of gait typically have an easier time stepping over something than they do kind of just trying to make that regular step. There's also a type of cane that has a laser pointer that when they're stepping or when they're walking, if they freeze up, they can actually use the laser pointer. It puts a red line on the floor and they can then step over that. So these are, they're not cures for freezing of gait, but these are ways that they can help prevent patients from falling because of freezing. So we go to the next slide. Okay, so the next one is postural instability. So this sort of still goes along with those other two. This is just having poor balance. It's one of the cardinal features of Parkinson's disease. When we're talking about patients who have Parkinson's, we're typically looking at patients who have tremor, stiffness, slowness, and then some sort of balance or gait abnormality. And once again, it's really important for us to know here if this postural instability appears to be dopamine responsive or non-dopamine responsive. So this is the type of patient who may say, yeah, I'm doing fine throughout the day, I take my meds, and then at some point when it's close to me being due for my next med, I'm not necessarily freezing or shuffling, but I just cannot make changes in position very quickly, right? So they go to turn a corner, they get off balance. They turn too fast, they get off balance. If somebody comes up behind them and they lose their footing a little bit, they can't regain that footing. So they are going to be at risk for falling. And so these are patients that, they're usually, if it's dopamine responsive, they're usually fine as long as their medication works. And we just have to work on keeping them on, as we say. But if it's a non-dopamine responsive postural instability, which unfortunately a lot of patients with Parkinson's have, Then we have to talk about walking aids. And so there's lots of different types of canes, there's lots of different types of walkers. And then of course, then there's wheelchairs that some patients will end up having to use. But postural instability can end up being one of the most debilitating parts of Parkinson's disease if it's not dopamine responsive or responsive to exercise. Okay, next slide. So as we get into kind of our next slide, I want to talk a lot about wearing off and going, being off and on. So as I've talked about shuffling of gait, freezing of gait, and postural instability, the thing that I've kept bringing up is whether or not it's dopamine responsive or non-dopamine responsive. And some of those things, like shuffling of gait, especially in the early stages of Parkinson's, tends to be a little bit more dopamine responsive, whereas things like freezing of gait and postural instability don't tend to be dopamine responsive, especially later in the course of Parkinson's. But there is this phenomenon that we talk about of motor fluctuations that include going from an on stage where your medication is working at its best and you can move at your best to an off stage. So the way that I like to explain this is when you are developing symptoms of Parkinson's disease, your disease is actually occurring prior to you ever having clinical symptoms. So before that tremor or that stiffness or that shuffling of gait has ever been noticed, you actually do not have enough neurons that make dopamine. So the brain is now getting used to seeing less dopamine. There's just not enough dopamine around. And then we diagnose you. And now we want you to move better. We want you to feel better and be able to kind of get up from your chair and walk around and have as close to a normal life as possible. So we give you back that dopamine, but we're giving you this back in, an external form, right? This is not what your body normally makes. This is not going to keep you steady throughout the day, because just like all other medications, you take a medication, it's going to wear off at some point, right? All medications are metabolized and are cleared from the body. So it's not going to last 24 hours for the most part. So you take the medication, your dose level goes up. That's what you'll see here on this slide, where, probably in that pink line is kind of where you feel good. And then at some point, you're going to kind of come back down and go off. So patients have these fluctuations where they'll be off before they take their med. Then they take their medication. They have a certain amount of time until they feel like they're on. Some people, that's delayed. It might take an hour or 2 hours before they really feel like they're on. Other patients, it's closer to maybe 20 to 30 minutes. And then they're on for a certain amount of time, and then they go off. And our goal is to take that next dose before they've gone completely off, so that their off is not as dramatic as it could be, right? So we get them before they have gotten really stiff and really slow. They're just, they're able to sort of recover and feel good again. But over the course of the day, they are still fluctuating. They're going to be up and then down and up and then down. And after years of doing this up and down sort of dance where they're on and they're off, you also have an issue where the receptors that accept the dopamine now kind of get confused. And so instead of this patient now just going from being on to off or off to on, they go from on to they go from off to maybe super on, was what I call it. And this is that dyskinetic group of patients. And this is one of the complications of Parkinson's disease and worsens with Parkinson's disease progression. So we can move on to the next slide where I'm going to explain it a little bit more. Okay. So with that super on, you have patients now who are having predictable wearing off, right? So they say, oh, I take my medication at 8 and I know that I can go until 12 o'clock. But if it, at 11:45, maybe I start feeling like it's off, and then my next dose, I go like that 3 to 4 hours and I feel good, but it's predictable, right? I always know it's going to be 3 to 4 hours. But then there's those patients who go that unpredictable side, and they have like, well, yeah, sometimes I'm on and then I randomly just go off. I can't predict it. I might be at the grocery store. I might be in the middle of cooking dinner. I might be, in the shower getting dressed, and I just go off and I cannot predict when it happens. It does not correlate to when I take my medication. You also have those patients with their delayed time to on. It just takes them a longer time to get to on in the morning. Those are the patients where it takes them like an hour to 2 hours before they really feel like their medication is working. And that kind of goes along with that extreme akinesia in the morning, which is just lack of movement. So they just have a really hard time before they've gotten started. And we know that about 50% of patients, between 40 and 50% of patients in multiple studies experience some degree of wearing off during the course of their disease. So next slide. So with those motor fluctuations, as I mentioned, we've had this kind of up and down cycle. And so they've been down a lot, in between their doses. And so then patients then develop these dyskinesias. And these dyskinesias are these writhing, kind of continuous, like voluntary movements. I almost say that they're dance-like. Actually, another name for dyskinesia is chorea, and chorea is Latin for dance. And so there's actually another video there that we could show at the end if we have time. But the best example that most people know of for dyskinesia would be the celebrity Michael J. Fox. So typically when he is seen on camera, he has a lot of neck movements or arm movements. Oh, no, we can go back one. Yeah, that are dyskinesia. And then some patients will even have what's called a dystonia. It can sort of still be in that dyskinesia family, but there's a few other questions I will ask about dystonia, because dystonia can also be an off symptom of Parkinson's. But this is an abnormal increase in muscle tone where the muscles go into an abnormal position. So this can be of the neck. So the neck might turn or might pull forward or pull back. The arm or the fingers may curl, or the toes may curl. Some patients, their toes may even kind of extend upward. And so dystonia is one of those things where if it's part of a dyskinesia sort of phenomenon, if it's one of those super on things, we want to kind of bring those dyskinesias back down. And if it's part of an off phenomenon where they're, now their medication is worn off, we also want to stop them from going off. So we can go to the next slide. So as we talk about the motor fluctuations, we talk about dyskinesias, over the last few years, there have actually been a few new medications that have come out on the market. And so these medications are Noriance, Gokoveri, and Ongentys. So the first one we'll talk about is actually, I'm actually going to go backwards on this slide. So Ocapicone was approved in April of 2020, so it's one of the newest ones. That's Ongentys. This is very similar to Indicapone, which we talked about before. Indicapone is a COMT inhibitor. It basically prevents you from degrading too much of your dopamine, so it keeps your dopamine around longer. Ongentys does the same thing, but the nice thing is it's a once-a-day dose, whereas Indicapone typically had to be taken with every dosing of your Carbidopa Levodopa, so usually at least 3 to 4 times a day. In addition to that, it peaks in the morning, so that's kind of nice. Patients can kind of take it at night, and then by morning, hopefully it keeps their dosing throughout the rest of the day better. So the thing about this is, even though it's not directly giving you more dopamine, it's helping to keep the dopamine that you have around. So you're not going to fluctuate off as quickly. So it helps to kind of keep you steady and keep you more in that on state longer throughout the day. So the next one is the one in the middle. That's Amantidine extended release, or Gokoveri. So I made a mention much earlier that Amantidine has been around for a really long time. It's kind of found by accident initially. It was actually a flu medication. And so they found that patients with Parkinson's who were put on Amantidine actually did really well, or actually started to improve. I shouldn't necessarily say really well, but they were doing better. And this was at a time when we actually didn't really have any other options. We didn't even have Senamet at the time. So Gokoveri is a extended release version of Amantidine. It's taken once a day instead of 2 or 3 times a day, and it also peaks in the morning. The nice thing about Gokoveri is it not only helps with motor fluctuations by keeping that patient more steady throughout the day, but for those patients who actually have dyskinesias, they can actually reduce their dyskinesias as well. So Amantidine is one of the few medications on the market actually only medication on the market, but of course in these multiple forms that directly reduce dyskinesia. So pretty much all other treatments may help motor fluctuations, and they may help on and off, but they don't directly help dyskinesia. And then our last one is the Norians, which is on the far left. So this one was approved in August of 2019, and this is a much different thought process in terms of how it works. It works through a completely different mechanism. So every other medication that I have brought up so far works through either giving you dopamine, activating dopamine receptors, increasing your endogenous dopamine, or keeping the dopamine that you make around longer. However, Norians does not do anything with dopamine. It's an adenosine receptor antagonist. So adenosine is a completely different neurotransmitter, and it's thought that this neurotransmitter actually may help you to have more off periods. So it kind of is like your brake. It's the thing that's kind of like stopping you a little bit. And so as Parkinson's progresses, patients have more activity of their adenosine receptor or their adenosine pathway. So they're off more, right? Instead of being on from the dopamine, they're now off because their adenosine receptors are kind of working overtime. So this pill, which is also taken just once a day, kind of lets that break off, for lack of a better scenario, like comparison, takes that break off of your off receptor and allows you to be able to move more. It does not directly help dyskinesias, but one thing that I do like about this is that sometimes as patients are fluctuating off and on a lot, we'll have to increase their dopamine medications, and so they may end up being on much higher amounts of dopamine. So once we take the brake off of this adenosine receptor, we can sometimes see that their dyskinesias may worsen, but then we would then be able to reduce your dopamine medication. That doesn't happen in all patients. I have some patients that may still need to be on the same dose they were on before, but it is an option for some patients. And the nice thing about all of these meds is they are one pill a day, but depending on the medication, there are a couple different doses. So we can go on to the next slide. Okay, so we've talked about mainly motor symptoms at this point that cause patients to fall. So we've talked about shuffling of gait, we talked about freezing of gait, postural stability, dyskinesias or dystonia. I don't think I mentioned it in the context of falling so much, but if you're moving around all the time, you are going to be at an increased risk of falling because you can easily get off balance. And remember, a lot of Parkinson's patients do have postural instability, so getting off balance because their leg is twisting a lot or their torso is twisting a lot can definitely be a cause of falling. But the next one that I'd like to talk about in the Parkinson's related falling scenarios is orthostatic hypotension. So this is sort of your dysautonomia section. Patients will complain of being lightheaded or dizzy. They may even pass out, which is what we call syncope, or they may have some other vague symptoms. They can say, oh, I just feel really tired, or I feel kind of weak, like I can't move. They may even get confused. So maybe family members say, there's a certain point in the day they just don't seem quite themselves anymore. And I've even had patients that even have staring spells and get kind of worked up for seizures because they're thought to maybe be having a seizure. So this picture here that you'll see is just this woman, there's a chair behind her. So presumably she's just stood up from a chair. She's grabbing her head and she's kind of, has her arm out because she's feeling unsteady or dizzy from standing up. So the cause of the symptom of this lightheadedness and dizziness is that the blood pressure is dropping when they stand. So Parkinson's patients are at risk for orthostatic hypotension. A lot of patients have it. Typically, it means that the top number or the systolic number of your blood pressure drops by about 20 or more points, and then your diastolic number drops by 10. And typically, if your blood pressure drops, you're going to feel lightheaded. And I always bring this up to patients because sometimes, with Parkinson's patients, we always have to discuss things like high blood pressure. A lot of patients with Parkinson's are over the age of 60, and so they may just have high blood pressure already. And so they're thinking, well, if my blood pressure is 130, over 70, why am I feeling dizzy? Well, what is your normal blood pressure is the next question I need to ask, because if their normal blood pressure is 165 over 95, because they're hypertensive, and then their blood pressure drops to that 130 over 70, they're going to feel dizzy because their blood pressure has dropped a lot. They just dropped from 165 to 130. That's 35 points. That's a lot. So blood pressure does not always have to actually be low in this category of patients. So of course, if it's 70 over 40, we are getting concerned. We definitely want to bring that blood pressure up. But I always make note that keeping a diary of the blood pressure when they're sitting and standing at home is also helpful, because we may see times when their normal blood pressure is pretty high and they're just dropping to like what would be a normal blood pressure, and then they're found to drop too low. So we can go to the next slide. So in this group of patients, if they're having orthostatic hypotension, I'm going to go through a whole list of options for them. The first one is, let's make sure that they're drinking enough water. Parkinson's medications unfortunately can lower blood pressure a little bit, and this patient population is at risk for dropping their blood pressure even more. So increasing their water intake is going to be one of the first things. And so I'll definitely want to make sure they're drinking 8 to 16 ounces of water first thing in the morning, and then possibly a little bit more water before their dose of medication. I've even found that a good number of my patients, just increasing water alone actually does help a good amount. The next thing would be maybe increasing their salt intake, or drinking things like Gatorade or Powerade, which have a lot of electrolytes. That can also help to raise the blood pressure. We do have to be cautious of this, though. If a person has heart failure, or if they have really bad hypertension, then I'm not going to recommend them increasing salt and Gatorade on their own. I may want to use something else. The third one is using TED hose on the legs or abdominal binder to kind of keep that blood pressure up, so that when they stand, blood is just not flowing to their legs and causing their head to get kind of dizzy. Elevating the head of the bed. So what this does is, this is actually trying to avoid what we call supine hypertension. So supine hypertension is just when they're laying down, their blood pressure gets elevated. So if you elevate the head of the bed, their blood pressure when they're laying down won't get as high. So when they stand up, hopefully there's not as much of a difference between their standing and their laying down blood pressure. The other way that we will avoid supine hypertension is making sure that their normal blood pressure is well controlled. Some patients go to bed and their blood pressure is 180 over 100. We don't want you to stay at, we definitely don't want anybody at 180 over 100. But if we can control that supine hypertension, then hopefully when they get up, they're not going to have such dramatic drops. We do have to be very cautious of this, because of course, if you have high blood pressure and you give a patient who also has orthostatic hypotension a blood pressure med to lower their blood pressure, they are going to be at risk for possibly dropping very quickly. And then the next option would be, if those other options don't work, would be to try some medications that can help to raise the blood pressure. So Florinef, Midodrine, and Mestinon have been used for many years. They work through different mechanisms between the three of them, but they do help to keep the blood pressure elevated. But we also have a fairly newer medication. So in April 2014, a medication known as Northera or Droxidopa was approved. It's a precursor to norepinephrine and actually does help to keep the blood pressure up. It comes in multiple capsule doses, and it's usually given about 3 times a day. I personally have actually had patients who don't have to use it all 3 times during the day, especially those patients who maybe they have a harder time in the morning because they've gone all night without liquids. Their blood pressure has been high overnight maybe, and then they stand up and it drops dramatically. They might need something like Northera or even one of these other oral medications just to keep their blood pressure up higher in the morning. And then usually sometime after lunch or dinner, they're doing a little bit better because their blood pressure is now on the higher side. Okay, we can go to the next slide. Okay, so this is actually the end of that whole Parkinson's related fall slide. So we had all of the motor symptoms that increase risk for falling. That's your shuffling of gait, your freezing of gait, postural instability, and your dyskinesias or dystonias that cause you to be off balance. And then you have your orthostatic hypotension, where you stand up, you get sort of dizzy, you might even pass out. But whenever I have patients coming in and talking about falls, even though I'm a neurologist and I treat a lot of Parkinson's patients in the movement disorder world, I also want to make sure there's not something else that we're not thinking of for Parkinson's that could be contributing. So we can go on to the next slide. So these are going to be our non-Parkinson's disease causes of falls. So it's not uncommon that I may have a patient and they're falling or their balance is off because they have lumbar stenosis, right? So this is like tightness in their back. It might be pushing on a nerve, and they may have some back pain, and their balance is just not quite the way it was. So this is not related to Parkinson's at all. Parkinson's does not cause a symptom at all, but it definitely can contribute to falls. And I may also have patients who may have Parkinson's related causes of falls, as well as the non-Parkinson's related causes of falls. And what we really always have to determine is, well, which one's contributing the most? Is it really maybe the non-Parkinson's cause that is the biggest culprit and we need to focus on that? Or is it both of them together? And fixing one is not necessarily going to help the overall risk of falls. So besides lumbar stenosis, then there's other orthopedic issues. So patients who have hip pain or knee pain, or have had knee replacements or hip replacements that haven't gone well, we have to think about those things. Another common one that I see in neurology is neuropathy. So these are the patients who have numbness in their feet. They may even have some pain and tingling. But these are patients who they just don't get quite the same sensory input from their feet on the ground as they normally would because their feet are numb. Another one to think about is vision loss. I don't think a lot of people think about this, but I'll have family members come in and they're like, yeah, my mom, my dad, they're falling all the time. And then I'm examining them and we realize, well, you know what, their vision's not quite the same. Do they have glaucoma? Do they have macular degeneration? Is there something about their vision that may be affecting where they are in the home, so that they're having, difficulty maneuvering around the home? Another thing that I didn't really bring up with the vision loss part, but it's also important, is making sure the patient hasn't had a stroke. If they've lost their, there was a question about that now. If they've lost part of their vision and they can't see peripheral, then it can make it hard to maneuver around the house. Another one would be vertigo. So vertigo sometimes gets called dizziness, but vertigo is a little different. It's really different from the type of lightheadedness, dizziness that people get when their blood pressure drops. This is more of like a spinning sensation, right? So they just feel really out of sorts. The world is spinning around them. There's lots of different causes for vertigo, but we definitely want to make sure a patient's not having vertigo as the cause of their falls. And the last one that sometimes gets it's kind of a mimic of Parkinson's, or can sometimes be confused for Parkinson's, is a disorder known as normal pressure hydrocephalus. This is a disorder where there's too much fluid on the brain, but it's not at an increased pressure standpoint, which is why it's called normal pressure. But it causes patients to have balance problems. Usually they have some urinary incontinence, they have some cognitive changes. So it can actually really mimic Parkinson's disease, but has a completely different prognosis and a different treatment style. So these patients would not be thought to get better from just giving them a little bit of dopamine as we would with a Parkinson's patient. So there was a question here about what symptoms of Parkinson's are similar to a stroke. So just to define a stroke is typically an acute loss of, we can stay here. So the stroke is a acute loss of blood flow to a certain area of the brain. And so with the brain, your symptoms that you have from any disease is really based upon the anatomy. So it's based on what part of the brain is affected. So, a stroke in one part of the brain can look very different from a stroke in another part of the brain. But some very common symptoms of strokes include weakness. So that would actually be difficulty lifting an arm or a leg, maybe a facial droop, slurred speech, numbness, or not really, sometimes they may have tingling, but more of a numbness or a loss of sensation. You can have vision loss or loss of peripheral vision as part of a stroke. and some patients can even have vertigo or, some sort of dizziness, depending on the location. So if we think about a stroke and the more common symptoms of stroke, and we think about Parkinson's and what we've talked about with like shuffling and tremor and stiffness and then postural stability, they kind of sound like they'd be very different, but sometimes it can be hard to differentiate between the two. Some of the things that I may notice are patients that come in with balance problems. So if you have a balance problem, yeah, it could be Parkinson's, but it could also just be that that patient's had a stroke and now their balance is off. If they have weakness, that's usually a clue that maybe it's not just Parkinson's, because Parkinson's disease typically is not a disease where a patient is weak. And I'll define it a little bit. So when I'm talking about weakness, I'm actually talking about the inability to move a limb against gravity. Now, a patient with Parkinson's may say, well, doctor, I feel weaker, because they may feel like they don't quite have all the same energy that they normally would. But hold on a second. Yeah, they feel like they don't have all the same energy as they normally would. But but it's not the same. It's not quite the same thing. Now, there are a group of patients who may have what we call like vascular Parkinsonism. So these are patients who have had, over the years, an accumulation of stroke-like symptoms, right? Or stroke burden on the brain, as we call it. So those patients may actually look just like a Parkinson's patient, because their stroke burden, their stroke insults they've had over years may actually occur in the same anatomical space as where Parkinson's develops. So the reason for their Parkinsonism is different, but it's actually caused by a deficit in the same area, so they look very similar. So I guess the easiest way to say this is strokes and Parkinson's can look very different, but patients with a stroke would probably have balance problems. If they have an accumulation of strokes over many years, their balance problems could look kind of Parkinsonian. They can have cognitive deficits. But typically it's the exam that helps me differentiate between the two. Of course, there's other supplemental tests such as MRIs and head CTs and CTAs that can also point me more in a direction of stroke or vascular issues versus like Parkinson's disease. So I hope that kind of answered that question. But yeah, so if there's any other questions, this is definitely the time to ask them.
Dr. Young, I'll go ahead and pull those videos up.
Okay, thank you. Yeah, so as she pulls up the videos, the first video was just a video to kind of see the typical symptoms of Parkinson's disease. So as I mentioned, Parkinson's patient usually has tremor on one side in the beginning. They can't have it on both sides though. They typically have stiffness and slowness and some balance problems. I think this is an ad.
This patient has a resting tremor, which you can see is affecting his left hand. Later in the tape, you'll see it affecting his right leg and his right hand and also his chin. It persists through most different positions of rest. This is a classical resting tremor of a patient with Parkinson's disease in the fairly early stages. His movements on the right side are quite brisk. When he tries the same on the left side, he finds it much more difficult and the hand movements slow down. This is bradykinesia. When he's walking, his left hand is not swinging, but you see it is shaking. And even though we talk of patients having a resting tremor, this does very often persist into walking. He's turning without difficulty and his walking is otherwise normal. This patient doesn't have any obvious tremor. She's sitting quite comfortably at rest. There's not really any significant postural tremor. Facial expression looks normal. Repetitive movements are satisfactory on the right. On the left side, she finds it slightly more difficult. Movements are slightly more broken up and there's a tendency to slow down. You can see that tone in the right arm is normal until such time as she begins to wave her left arm, when you can see the right arm stiffening up. On the left side, on the other hand, tone is increased even with the right arm at rest. She again moves the contralateral limb and you can see a considerable increase in tone. The next patient you're about to see has some even more unusual movements. This young lady has a long history of back pain and a several-year history of these apparently involuntary leg movements. This goes on all of the time for weeks on end, but every now and then she has a day or two's break. And as a result of these movements, she has to be carried around at home by her parents. You can see that when I touch her leg, the speed and the amplitude of the movements increases considerably. After a while, it settles down a little bit again. And in a moment, I hold her leg slightly more forcefully in order to see whether.
Okay. And then if the last, I think the last one shows dyskinesia. So dyskinesia, as I mentioned, that's sort of that dance-like writhing movement, and that's a complication of Parkinson's disease. I know one question that always comes up with patients is they've been told that it's a complication of the medication. It's not directly just a complication of the medication. It's a complication of giving levodopa from an exogenous form to patients with Parkinson's disease over years. So these are patients who are going to have more difficulty maintaining normal levels of dopamine throughout the day. Oh, you can start it, sorry. Throughout the day. So they're sort of fluctuating up and down for years, and then they develop dyskinesia. Okay. So you'll kind of see here, this woman has her right leg is like twisting, moving inward a lot. She has some on her left leg as well, but it's worse on the right. Same thing with her right arm. There's even probably more of what we call like that dystonic posturing. Her right arm just seems to kind of be pulled in a little bit more in those earlier, the earlier video. And then there are some risk factors for dyskinesia. So patients who were younger at the onset of the onset of Parkinson's disease, women and patients on high doses of Carbidopa Levodopa or other dopamine medications are at a higher risk for dyskinesia. That's one reason why we do try to keep the dose lower for as long as possible. But unfortunately, some patients do need higher doses sooner. But yeah, that's probably the reason why some people think it is directly a result of the medication, but it's more of that dyskinesias will worsen in the setting of dopamine. Okay, any other questions or any questions?
I haven't seen any come through the chat, Dr. Young. Thank you so much.
No problem.
I really appreciate you coming out, and thank you everyone for coming out either to your center or taking a view from home. So thank you so much. We really appreciate it. I learned a significant amount, so I hope everyone else did as well. Selena, are you still on? All right, well, I guess we will go ahead and conclude our session for today. We hope you have a wonderful weekend and stay safe. Thank you so much.